Hello, it's Denise Hubble, respiratory therapist. We're chatting today about blood. Some of the most important things to think about with blood is that it's transport medium to carry all important things to the cells and carry waste from the cells back away from the cells so that they can be dealt with by things like the kidneys. Also, an amazing thing about the blood is basically it has a desire to not be lost by the body. As in, if we cut ourselves and we're bleeding, there's an entire mechanism in place called the clotting cascade, which is designed to stop that bleeding from occurring so that blood can be saved by your body or retained by your body so that you don't bleed out. So these are some of the things that we're going to be looking at in this lecture. Blood can be separated into two parts, the formed elements, which are the cells, and the plasma, which is the non-living part of the blood. They call it here the non-living fluid matrix. Because blood is a connective tissue, it does have these two components, a portion of it which is considered non-living, and then it has the living cells. A vial of blood can be put into a device which will spin it very quickly. It's called a centrifuge. And when the blood is spun, the most dense items will fall to the bottom and the less dense items will rise to the top. And that's what this slide starts to talk about here. So let's see. So our erythrocytes sink to the bottom. 45% of the blood, they're known as hematocrit. This is our red blood cells. So they're going to fall to the very bottom. And then we're going to have a layer called a buffy coat, which includes leukocytes, those are also known as white blood cells, and platelets. So they make up a thin little layer in the middle. And at the top of the vial, if we were to look at it, we would see a more amber, sort of clearish looking fluid called plasma has risen to the top. It makes up just over half of the blood typically. Here we can see a bit of an image of one of those centrifuges spinning the blood at the top of the page. And then in the middle of the page we see that vial again with those three layers shown. At the bottom we see in red the red blood cells. They have kind of fallen to the bottom. And in the middle we see the white blood cells and the platelets in the buffy coat, we call that. And at the top is sort of a semi-transparent amber colored fluid called plasma. So let's take a look at these, what makes up these things. This is an important slide. It has a lot of detail here. On the left, we look at plasma. So let's take a look at plasma and what's in it. Well, of course, it's mostly made of water. That seems logical. We also have salts, which are listed there. Plasma proteins. I want to mention here albumin. Albumin is one of the most important plasma proteins. It's a large protein. It has a strong oncotic pressure. And it plays a large role in Starling's law of the capillary. If our patients have a lot of excess fluid outside of the blood vessels, they may be given a product known as 5% albumin or 25% albumin, which has a high oncotic pressure and will draw fluid back into the blood vessels due to its high oncotic pressure. In a very simplistic way, we could think of albumin as a sponge because it has a tendency to draw water towards it. So if a patient is administered albumin, then we know that it will act like a sponge and draw fluid into the vascular space. Okay, so also under plasma proteins we have fibrinogen and globulins, and listed there what their functions are. And then a few other things are listed near the bottom, including nutrients, urea and uric acid, respiratory gases, and some hormones, of course. On the right, let's talk about these formed elements. These are the living cells of the blood. That's a simple way of looking at it. We have erythrocytes, also known as red blood cells. You probably know that these are responsible for carrying oxygen and CO2. And we have leukocytes, which are white blood cells. These guys are our army of fighters. They're going to fight any invading microorganisms. We're going to study those lots. And platelets are actually cell fragments. They're not actually full cells. But they are involved with blood clotting. You could think of them as glue. They are involved with the clotting cascade and very important in the clotting of blood. So if a patient has a low platelet count, I'm pretty nervous to do an arterial blood gas, for example, or anything else that invades a vessel of the body, because it's going to be difficult for that patient to clot. So that's the relevance of understanding about platelets. Blood has interesting qualities, like truthfully, it is sticky and opaque and very thick. It's interesting that oxygen-rich blood is scarlet red. That's very important, because when we do an arterial blood gas, we immediately look at that blood and kind of analyze mentally if we think it's well oxygenated blood or poorly oxygenated blood based on its color. So this is very accurate and relevant about the color of the blood. We of course want to see that pH be between 7.35 and 7.45 ideally. We know that the respiratory and urinary systems and buffering systems are responsible for maintaining that. Our blood volume is around 5 to 6 liters normally in healthy individuals. This is a microscopic image of blood. We see that platelets are very small. They're cell fragments and they're involved with clotting, we know. We also see mostly here in amber erythrocytes, which are red blood cells and they carry oxygen. In purple, we see neutrophils and lymphocytes. Those are a couple of examples of white blood cells, which we know are sort of fighter cells. Those are two examples of those. Very important to remember that erythrocytes are also known as red blood cells and that they're basically bags of hemoglobin. They have no nucleus, so that makes them unable to divide and reproduce. They have a life of about 120 days. And they have a very important role in carrying oxygen. So if you have low red blood cells, you have poor oxygen carrying capacity. Hemoglobin contains iron, and it has the ability to bind to 4 oxygen molecules. And we see that each erythrocyte or red blood cell contains millions of hemoglobin molecules. So that's how we understand that hemoglobin carries oxygen, as does red blood cells or erythrocytes. It is very important that our patients have an adequate amount of hemoglobin to carry oxygen to the tissues. If they have a low hemoglobin count, then we know that they're not going to be able to carry as much oxygen to the tissues. A normal here is given of 12 to 18 grams per 100 mils of blood for hemoglobin. So let's say, for example, our patient's hemoglobin value is 7 instead of 12 to 18. They basically have half the ability to carry oxygen to the tissues. This can make the patient not have a high enough oxygen content, not have a high enough oxygen delivery to the tissues, and their body will try to compensate by increasing heart rate, for example. I'm amazed by white blood cells, also known as leukocytes. As I mentioned before, these are basically our fighter cells to fight invading microorganisms, also known as infection in the body. So we need to have an adequate number of white blood cells to be able to fight effectively. If you've ever heard of somebody who's received chemotherapy, often their ability to produce white blood cells is low, and so their white blood cell count is low. So it probably is understandable to you then they can't fight infection well. That's why when we have a patient who's received chemotherapy, as a healthcare worker, we need to glove, gown, and mask, because we're protecting that patient from any infections we may have, because they wouldn't be able to fight that as well. On the other hand, if we have a otherwise healthy patient who has recently picked up an infection, we can do blood work called a complete blood count and look at the white blood cell count. We'll see that it's elevated, so it's going to be high in a patient who's otherwise healthy but has infection, because they've increased their number of white blood cells in order to fight that infection. So, just to really solidify that, white blood cells are involved with fighting invading microorganisms. It mentions here that they can move in and out of blood vessels. They can move into tissues, for example, in order to fight that fight. There's a term here called positive chemotaxis, which the idea is that damaged tissues can send out chemical messengers to invite white blood cells to the area to try to help fight. And there is the normal blood count, 4.8 to 10.8 white blood cells would be the way that we actually monitor that in the hospital. If we performed a differential on a patient, that would mean that in the medical laboratory, they took a look at the white blood cells and divided them down into their types. We're going to start to look at those now. So in the medical laboratory, they put a stain on the blood, and granulocytes or agranulocytes are going to look different under the microscope. So that's why leukocytes are divided into granulocytes or agranulocytes. So when we look at granulocytes, there are 3 types that we look at: neutrophils, eosinophils, and basophils. So neutrophils are the most common type of white blood cell that we have. They're very active during infection, and if you have an infection, the number of these will increase dramatically. There's the normal count of them. Eosinophils have a great role in fighting parasitic worms, and they're involved with allergies. So if you are experiencing either one of these, then the eosinophil count will be higher. And basophils contain heparin and histamine, which we're going to study more soon. So all three of these are types of granulocytes. And agranulocytes, of course, look different under the microscope. So these again are white blood cells or leukocytes, just that they look different when the stain is put on them and we look at them under a microscope. So the two types of agranulocytes are lymphocytes and monocytes, and as it mentions here, lymphocytes mostly are in lymphatic tissue, but they're also in blood, and they do play a role in the immune system. We're going to actually look at two types of lymphocytes when we look at the immune system, B cells and T cells, so we're going to further divide those lymphocytes later on. Monocytes, these are like Pac-Man, if you've ever played that game. They have the ability to perform phagocytosis, they migrate into tissues and can basically engulf microorganisms. They play an important role in fighting chronic infections. Platelets, in a most simplistic way, we could think of platelets as the glue of the blood, which platelets are required in order for proper clotting to occur. So if your platelets are very low, I mentioned before, we wouldn't want to be doing too many invasive procedures on the patient. Also, if platelets are very low, a surgeon is not going to want to perform surgery on the patient because it would be worrisome that they wouldn't clot properly and they would bleed out. A few big words here. Hemopoiesis is the process of your body producing blood cells, and these blood cells are derived from a stem cell termed hemocytoblast. We see that hemocytoblast stem cells divide into lymphoid or myeloid stem cells, which then further divide into our regular white blood cells that we've discussed and our other blood cells. So the lymphoid stem cells divide down into lymphocytes, and then the myeloid stem cells divide into all of the other cells that we've been studying. So the erythrocytes, which are red blood cells, our platelets, which are involved with clotting, and then the last four, monocytes, neutrophils, eosinophils, and basophils, are 4 of the 5 white blood cells. It is interesting that because red blood cells have no nucleus, they aren't able to reproduce or grow. So we see here that they wear out in about 120 days. Amazingly, your spleen and liver actually phagocytize the cell, so engulf the cell, and try to recycle a lot of the important contents of the red blood cells. Also very interesting, if you have low oxygen levels in your blood, this stimulates the kidney to produce something called erythropoietin, and erythropoietin stimulates the bone to produce more red blood cells. Here we see that phenomenon that I mentioned in the previous slide. So if there's low oxygen content in the blood, then the kidneys are able to recognize this and release erythropoietin, and the erythropoietin tells the red bone marrow to produce more red blood cells. Now we have increased red blood cells, and that should improve the oxygen carrying capacity to the blood. This is simply amazing, and it is a great example of a negative feedback mechanism where something became out of range and a correction was made to get it back into range. Very interesting though that when we are assessing a patient with emphysema, these patients tend to have low oxygen levels chronically. So for years and years they'll have low oxygen levels. So this process will occur over years and years. So you probably understand then they can actually develop a lot of hemoglobin, so much hemoglobin that their hemoglobin levels get very, very high. For example, 18 might be a measurement that they have. This actually leads to their blood getting too thick. So can you picture their blood being like molasses? It's so thick. And this is hard on their heart because the heart of these patients has to pump that blood around the body. And if now that blood is like molasses, can you imagine how difficult it is to pump that blood around the body? So this is very interesting that it's a great mechanism generally, but it can become too far for our emphysema patients and create too thick of blood and cause heart failure for those patients. Hemostasis is blood clotting. When we injure ourselves and we are bleeding, we need to clot so that we don't lose too much blood. So we're going to look at that process here. It's very interesting. The first part is vascular spasm. So the vessel begins to spasm so that there'll be less bleeding at the site. And then we're going to look at something called platelet plug formation and then actual blood clotting. So with platelet plug formation, it's very interesting that once there's damage to the vessel, these collagen fibers are kind of waving in the blood flow. And this causes platelets to stick to them. And as soon as those platelets start to stick to them, they release chemicals, it's called chemotaxis, release chemicals to attract even more platelets. And we get this platelet pileup that forms a platelet plug. So this is a way of immediately stopping bleeding at that site. So a platelet plug has already formed. Now it's time to form the clot. This is termed the clotting cascade. It involves 13 clotting factors and vitamin K. If you're missing any of those clotting factors or vitamin K, it's difficult or impossible for the clot to form. And you may have heard of hemophilia. There are a couple types of hemophilia, but they involve missing some essential clotting factors. If you are unable to clot, then you're going to bruise easily, and anytime you have an injury, there'll be profuse bleeding. So let's take a look at this clotting. It mentions here that the injured tissues release something called tissue factor, and it performs chemotaxis and invites all the clotting factors to come to the area for a clot to occur. Something called phosphorus trifluoride interacts with the tissue factor and blood protein clotting factors and calcium to trigger a clotting cascade. When this clotting cascade is occurring, prothrombin activator converts prothrombin into thrombin, and then thrombin joins fibrinogen proteins into insoluble fibrin. This fibrin forms a mesh covering basically of the clot. So we could picture that as a little mesh laying down in the area. That mesh that's been laid down then traps red blood cells and platelets, forming the clot. This is an image of a blood clot containing a mesh and red blood cells and platelets. A blood clot should be able to form within 3 to 6 minutes, but of course if any of these clotting factors or vitamin K or calcium are missing, then that's going to take longer. The blood clot remains while the endothelium of the vessel tries to repair itself, and after that time then the blood clot is broken back down again. A couple of terms here, thrombus and embolus. A thrombus is when a clot forms in a vessel that actually isn't ruptured. An example of a thrombus is in the coronary arteries. These are the arteries that supply the heart muscle, the myocardium. Sometimes a thrombus forms in these blood vessels and can lead to a myocardial infarction, which is termed a heart attack, because it blocks the vessels and therefore stops the blood flow to the heart muscle. An embolus is a thrombus that has broken off and is floating in the blood and then lodges somewhere else. For example, it could lodge in blood vessels in the brain and cause a stroke, or it could lodge in blood vessels in the lungs and cause a pulmonary embolism. These things can actually be fatal. If a patient loses blood, they will become anemic, and then we know that their oxygen carrying capacity is low. We are hesitant to transfuse blood products to patients unless absolutely necessary because of the risk of transmitting diseases. So most physicians will wait until the patient's hemoglobin levels dip to 7 grams per deciliter. At this point, they'll often order 2 units of packed red blood cells. It is estimated that each unit of packed red blood cells will increase the patient's hemoglobin level by 1 gram per deciliter, unless there's substantial bleeding still occurring. And of course, the hemoglobin levels will continue to drift downwards. If a patient is to receive donated blood products, blood typing must be done to ensure that there won't be a transfusion reaction. There is ABO blood typing and RH blood typing. As you can see here, type AB patients are considered universal recipients. They can receive any of the other blood products. And type O negative actually is the universal donor. Blood typing is also done according to Rh negative versus Rh positive blood products, and it mentions here that an Rh negative person should not be receiving an Rh positive blood type because it can lead also to a transfusion reaction. To determine the blood types in the medical laboratory, different agents are added to the blood, and the blood is observed for agglutination and lysis, which means basically clumping and breaking down of the blood. This helps identify the blood type. Another step can be done called cross-matching if the time permits clinically. That is when the patient's blood and the donor's blood are actually mixed together in the lab and observed to ensure that there is no reaction between them. This is a very nice thing to do if time permits.